Ladies and gentlemen, good afternoon and welcome to this session in the London studio on valvular disease. The next hour, we're going to discuss coronary access after TAVI. My name is Nicolas Van Mieghem from the Erasmus University Medical Center, and it's a pleasure to be joined by Professor Joanna Wykrzykowska from Groningen, who will be our chat master, and also Professor Abdel-Wahab from Leipzig, Professor Carbanda from Oxford, Dr. Andreas Ruck from Karolinska in Stockholm. And we're going to dive into this issue of coronary access and why a TAVI platform also matters. This is a very timely topic because we are moving to lower risk patients, younger patients. So it is expected that patients with a longer life expectancy might at one point after their TAVI procedure require another coronary angiogram. So with that, I want to encourage the participants also to join in the chat room. Your chat questions will be answered, and we'll also try to use your chat questions in the panel discussions. So without further ado, it's my great pleasure to introduce the first speaker, Professor Mohamed Abdel-Wahab, to discuss the issue of coronary access after TAVI.
And so in the next few minutes, we're going to talk a little bit about coronary access after TAVI and why this is becoming a growing need. So these are my potential conflicts of interest. So, of course, we all know that transcatheter aortic valve implantation is now, or has now become the dominant form of aortic valve replacement in the majority of European countries and in the United States as well. So these are numbers you see on this slide from Germany between 2011 2019, and you can see here what we know from similar studies from other countries, that the numbers of TAVI procedures has steadily increased, which has been accompanied in recent years by a decline in surgical procedures. And so we are expecting, of course, in the future, even a larger number of patients carrying transcatheter aortic prothesis and potentially requiring coronary interventions. This is also important in the context of the fact that coronary artery disease is very highly prevalent in patients currently treated with TAVI. This ranges somewhere between 40 and 80%, really depending on the population that is being treated and, of course, the age of the patients included in these different studies you can see on this slide. But this means that almost every second TAVI patient has some sort of coronary artery disease that would potentially require percutaneous intervention. It's also important in this context to underlie the fact that evidence concerning revascularization before TAVI is very limited. And this has been also reflected in the very recently published ACC/AHA guidelines on valvular heart disease, where you can see here that the recommendations to perform PCI prior to TAVI is a class 2A recommendation, but is associated with very limited evidence. The recommendations are for those patients who have left main or proximal disease, but again, this is based on mostly small retrospective registry studies, and we don't have a plethora of randomized trials in this context, which would mean that the decision to perform PCI before TAVI or the practice patterns are very heterogeneous. So a lot of patients may undergo TAVI procedures even in the presence of significant coronary artery disease without being treated before TAVI and may potentially require treatment afterwards. Retrospective studies therefore indicate a range of somewhere between 3 and 6% of consecutive patients requiring PCI after TAVI. The number would be higher if we count coronary angiograms without performing PCI as well. And this occurs more or less somewhere between 1 and 2 years after TAVI, if we look at the median time to post-TAVI PCI. And we expect, although we don't have data in this context, but I think this is common sense, that as TAVR indication expands to lower risk and younger patients who have a better long-term prognosis and have a longer life expectancy, there will be an increasing need for repeat angiography and PCI due to progressive coronary artery disease or the development of acute coronary syndrome even more. So this summarizes why coronary access after TAVI is a growing need, but it could be also potentially a growing concern, because there are some difficulties with obtaining coronary access after implanting a transcatheter prosthesis in the aortic position. This is just a case example which shows you difficulties in performing a coronary angiogram after implantation of a long self-expanding Evolut device. And in this particular example, you may even find difficulties in appreciating the type of catheters that are being used to engage the coronaries, which more or less signifies how the operator is struggling to selectively engage the coronary arteries. We can take this even a step further, and this is a very recent publication from a multi-center trial, a multi-center registry that looked at patients developing STEMI after TAVI. And you can see here that these patients have, as we might expect from the difficulty in obtaining coronary access after TAVI, they have significantly longer door-to-balloon times compared to patients who do not have a transcatheter prosthesis in place. They have a significantly higher failure rate of PCI, so 16.5% PCI failure rate in this registry in patients presenting with STEMI, and consequently they have a very high mortality of up to 25% during the in-hospital period. So there are difficulties and there are concerns. These difficulties are related to known anatomical factors, which relate, for example, to the surrounding anatomy, coronary height, the width of the sinus of Valsalva, and so on and so forth. But they are also related to the device that is being implanted there, to the device type, to the device size, to the device height, to the orientation of the device. I remind you, of course, that these devices have different height of their ceiling skirt, they have different height of their commissural tabs, and all of these factors could interfere with coronary access. This is not only theoretical, but it has been recently shown in a very elegant prospective study by Marco Barbanti, where 300 patients have been included, and coronary access has been obtained before and after TAVI. And you can see that in this study, there are certain predictors for unsuccessful coronary access that are more or less reflect what we just mentioned. So there are some anatomical predictors, there are some predictors related to the prosthesis position, and there are some predictors related to the prosthesis type. What we also understood very recently is the issue of commissural malalignment. So surgeons implant surgical valves adapted to the native anatomy and align the new commissures to the native commissures. This is a potential advantage because it facilitates or could facilitate coronary access through its natural way. What we know now from different studies is that when we implant TAVI devices without taking care of commissural alignment, that we could have severe malalignment in up to 30% of patients and any form of malalignment in more than 50% of patients. The last slide of this short presentation tackles the potential solutions and perspective, and I'm sure this will be discussed in the presented case and in the following discussion. So we should be aware of the factors that interfere with coronary access in prostheses that have already been implanted in position. And we should all be aware of the tools and techniques we have in order to access the coronaries in challenging situations. But we should also pay attention to the coronary access in planning the type of prosthesis that is going to be implanted, in our implantation technique, and also in the technological improvements that should be done in the next generation devices. And again, a lot of these aspects focus again on the concept of commissural alignment or malalignment. By this, I think we can move to the discussion and to the case presentation. And thank you so much for your attention.
Thank you, Mohamed. That was comprehensive in 9 minutes, only in 9 minutes, a lot of information there. But before we go to the recorded case from Karolinska, maybe a short question to you to begin with. Age and the risk profile of the patient, does that have effect on the practical planning of the patients? I mean, in terms of the coronary accessibility, would your approach be different for a younger patient relative to an older patient, or is it one approach for everybody?
Well, this is a very good question, Nicolas, and I think it's not one approach for everybody. I do believe that we are now improving and refining our techniques. Similar to what we did over the years in coronary interventions. So you don't have one technique for doing a bifurcation. Maybe you had this 20 years ago, but now you have multiple techniques. And I think we are like moving in the same direction with transcatheter therapies as well. So you can adapt what you're doing according to the patient needs and to the patient's anatomy. And this is the beauty about that. We are now learning how, for example, to choose device types, how to do commissural alignment with specific device types. So probably you don't need to do this in a 90-year-old lady who doesn't have coronary artery disease, because she will never develop it. But you need to think about this in a younger patient who has the potential to develop coronary lesions or already has coronary disease, and then you need to think a little bit differently.
Yeah. Okay, and Professor Karbanda, also for you, Raj, the question, do you select your device platform based on coronary accessibility? Do you feel that some devices are more prone for issues with coronary reaccess?
Thank you, Nicolas. I would like to say that we are thinking much more about that now. TAVI has evolved, and I think we're now at a stage in TAVI where we're being much more refined about looking at that particular question. So device selection, as you know, is, we don't really have algorithms for it, and a lot of it is based on personal preference. But I think what we're doing much more is understanding much more about the anatomy, the STJ, the relationship of the sinus of Valsalva. And I think these things need to be taken into much more consideration in terms of planning the procedure and planning the right device for the right patient. So in answer to your question, yes, I think we're now at a stage where we need to think about the right device for the right patient and the right anatomy. Age is one factor, coronary access. And I think the other thing that comes into this is the need for future interventions, as these younger patients are likely to need valve-in-valve procedures. And that becomes even more critical, particularly in terms of commissural alignment, for example, which becomes even more relevant.
So that's the perfect bridge to the recorded case, because as we have selected our device or our device platform to do the TAVI, you also have to make sure that you implant it the correct way. And this is where, among others, commissural alignment comes into place. So the floor is now to Dr. Andreas Ruck from Karolinska and his recorded case. So we can maybe first start with the introduction of the patient.
Hi, my name is Chris Meduri at Karolinska Institute here in Stockholm, Sweden, and I'd like to talk to you about commissural alignment with the accurate valve. I think a really important topic going forward. Next slide. So I think before we dig too deep, we have to understand what commissural alignment is and what it's not. And really, with the accurate valve, it's important to understand that commissural alignment involves having the post of the transcatheter valve in the native commissures. What they aren't is completely misaligned. And I think this is a critically important point because we're starting to realize that we can achieve easier coronary reaccess with appropriate commissural alignment. It will help facilitate potentially leaflet modification need for valve-in-valve procedures downstream, and also may reduce PVL as it sits more naturally in the valve. Next slide. So here you can understand that we have different degrees of alignment. If we are severely misaligned, we have that post directly in front of the coronary artery, and even coronary access could be quite challenging. If we're moderately misaligned, it's just 20 degrees less off, still quite challenging. And what we really want to achieve ideally is a none, but at least mild or less. And then if you look at the next image, we often will see that there may be two posts on the outer and one wing on the right, and this orientation will just clock the catheter 30 degrees. And if we have the opposite orientation with two posts on the in and the converse and the wing on the out, we will then counterclockwise instead. And by doing this, we will then achieve an optimal alignment. We do this with the marker at the top of the pigtail and go in, and it's really quite simple. Next slide. So to summarize our technique here, we want to confirm in the left-right overlap, achieving the 2-1 with the right wing. And then we want to assess and achieve in the left, the three-cusp view. If it's 1-1-1 already with the two wings, we're good to go. If it's not, we then counter or clock depending on the orientation to achieve, again, the three-post, two-wing orientation, and then we go to our final deployment.
Welcome to Karolinska University Hospital. I would like to take the opportunity to show you a case using commissural alignment and the accurate Neo2 valve. My fellow operators will be Nawzad Saleh and Christopher Meduri. Next slide, please. Today we have a patient, 78 years of age, female, small body size. She has a history of radiation for Hodgkin's lymphoma, also of cancer surgery for lung cancer. She has bilateral slight coronary disease with moderate stenosis of the LAD at FFR of 0.81 and a borderline stenosis of the RCA as well. She's treated with warfarin. She has aortic stenosis with a Vmax of 4.3 meters per second, the normal LV function. You will see the CT picture on the right with a perimeter-derived diameter of just 19.8 millimeters, and with some calcium on the borders of the annulus to more than one side. So a little bit challenging maybe for the sealing of the valve. The procedure plan is to use the accurate small valve to pre-dilate with an 18 millimeter true balloon and likely to post-dilate with a 20 balloon if needed. Next slide, please. Just to introduce the concept of the different views we use for implantation, this is the traditional three-cusp view. You see as we move to the left-right cusp overlap view, we have the yellow dot showing the non-coronary cusp, and you see that's isolated in the cusp overlap view. Now we're back to the three-cusp view. Thank you, and on to the case.
So how cool is that to see my very sympathetic friend, Chris Meduri from the United States in Karolinska. So my first question to you, Andreas, in terms of this commissural alignment that Chris so elegantly explained to us, is this a trivial part of the procedure, or is this a key feature nowadays when you implant these kind of valves?
I would say nowadays it's a standard of care here, but only since a quite short time. So we started working on this really just around the end of last year, and we worked together with some technicians and engineers at Boston Scientific to come up with the best way. And I must say, in the beginning, when we didn't have the exact same technique as now, it was kind of a struggle to get this correct, and quite often we were not perfectly aligned. But now, since we have a very standardized technique now, which every operator follows here, we have 5 different operators. I can tell you in the last 36 cases in a row now, we have a good alignment in all cases, and even less than 15 degrees malalignment in most of them too. So it's actually nowadays just adds like 2, maybe 3 minutes to the case.
That seems worth it, I think. Raj, what is your experience with commissural alignment? Is this something that you practice on a regular basis, or is this more the exception?
It's certainly the exception for us at the moment. I think, and I think like most operators, we're learning about the concepts around commissural alignment. I think of the valve types, the Accurate Neo platform probably has the ability for us to do this in a consistent way. And I think we're still at the early part of our learning curve in terms of getting to grips with understanding how we modify our implant technique to achieve this and what it means. I think we are still, at the early stages, but this is a really interesting concept, and I'm certainly keen to learn more about it as we're, from the likes of the people that are going to show us.
Yeah. Well, and there are subtle differences. There is, of course, also commissural alignment with supraannular functioning self-expanding valves, which is a little bit of a different approach to it. What I like with this technique is that you can use it in the coplanar view, and then you can confirm if needed with a cusp overlay. So I would never use cusp overlay to really implant the valve, but I would use it to help me with the commissural alignment. And I do that kind of approach for both the self-expanding valve systems that we have in our practice. Mohamed, a question for you. How is your practice with in particular the Accurate platform? Are you using this commissural alignment?
Yes, so very similar to what Andreas mentioned. I mean, this is gaining momentum in the last 6 months, I would say. So, I mean, we are starting to learn how to do it. There are several groups working on a little bit different techniques, but I think more or less pointing in the same direction. Because the good thing with the Accurate platform is that you actually can see the commissures of the device, even when it's still crimped inside the catheter. So this is a big advantage compared to other devices, that you don't need to imagine a lot of things in your mind. So it's rather simple to understand, particularly if you combine it, as you said, with only like one additional fluoroscopic projection, just to make sure that you are thinking in the right direction. Yeah. So I think it's evolving. So there's no there's no gold standard 100% yet, but it's evolving in the correct direction.
Yeah, you were involved, of course, with the SCOPE trials, the SCOPE family of trials with the Accurate. We're now discussing Accurate Neo 2, which is, of course, an iteration of that other generation. What, in your opinion, are the major differences with Accurate Neo 2? Where are the advantages?
Yeah, so I mean, what's different in the device is that it has an additional outer sealing skirt, which aims at improving paravalvular sealing. An additional thing on the catheter is that you have a radio-opaque marker that should facilitate the correct placement of the device in the correct annular position. To tell you the truth, the addition of this radio-opaque marker was not the major change that is in my opinion, the big plus for the Accurate Neo 2, but I think the sealing skirt is. So in our experience, and we started, I think, in September 2020 with the Neo 2. So step by step, we are doing more complex anatomies with the device just to understand how it performs. And up till now, we are very satisfied. So it seems to be the sealing properties seem to be much better. And I think Andreas may want to comment on this because of the data he just presented at EuroPCR from the early Neo 2 registry were actually very encouraging for this particular point.
Andreas?
Yes. So we showed the data just a day or two ago. That's the early Neo 2 registry, where also Leipzig took part, for example. And we had 12 European sites, and to make it short, the rate of moderate PVL was just 1.3%, which is way lower than we have seen in the other major trials with this device. That's so far based on the site's own readings on the echoes, but we will also have a core lab to present later with both quantitative aortography and also echo data.
I haven't seen those results yet, Andreas, but was there a penalty in terms of pacemakers or not?
It was 6% pacemaker, so it's actually lower than in the scope studies too.
Yeah, so that's excellent. So it's still single-digit numbers in terms of pacemakers, and basically very low numbers of more than mild PVL that is similar to the competitors. So quite favorable data. Okay, so why don't we move to the remainder of the case? So the next 10 minutes or so.
Welcome everybody to Karolinska University Hospital. We're about to show you a case today using the Accurate Neo2 valve in a patient with a very high surgical risk and with borderline coronary stenosis, where we think some of the advantages of this valve system, including the possibilities for commissural alignment, will be highlighted. I'm Andreas Ruck. On my side, I have my colleague Chris Meduri, and we have Nawzad Saleh with us during the case. So we have at the moment the femoral access established with the 14 French sheaths from the right side. We have the pigtail in from the left radial, and the patient has a permanent pacemaker, as you will see. So we'll use the wire pacing system for the pre-dilatation for the rapid pacing. Absolutely. Maybe we can go to the camera here to show. So here we have a wire in the groin, in the skin. It's connected to one, I think it's a positive, the red side here, and then the black one will be connected to the wire which goes into the left ventricle.
Exactly. Great.
Okay.
So I think this is we'll bring the balloon up now, and I think, so we're using an 18 balloon here. The annual size at 19.9. Typically, we actually size even a little more aggressively, but we don't have 19 true balloons. We would typically pre-dilate with the balloon that's sized within the same diameter, 1 millimeter of the annular size. And I think it's an important point, and Andreas Nawzad, you can comment on this, that really you have to think of Accurate, I think, differently than your typical self-expanding valve. You really have to open up and facilitate the expansion of the valve initially with a really, I think, a pretty aggressive pre-dilation, and then consider to be a bit aggressive on the post-dilation as well. It maintains its radial force at the final expansion, but it's important to really open up that space.
Okay, so we're ready to go with the 18 balloon in place, as you see. Mm-hmm. So we will then start the pacing. So is pacing ready? Balloon is ready?
Yes.
Okay, pacing on. Balloon up. Balloon down. Pace off.
Great. So now we'll get ready to come in with the valve. And if we could put up the first slide here, we do really want to spend some time emphasizing a technique we've spent quite a bit of work on, which is developing really, I think, a very efficient method of providing commissural alignment with this valve. We'll have already talked about that a little earlier, but our goal views, as you can see on fluoroscopy, when we're trying to orient things in our left-right view, we're going to talk about stent post and the wing. And so in our left-right view, we're going to want to have one wing on the inner curve, and those stent posts are going to have two on the left, one on the right, or on the inner. And on the three-cuts view that we'll explained earlier, you're going to want to have three separated stent posts at the top, and then these kind of symmetrical wings a little bit lower there. And so those are the things we'll be looking at for here.
So the left-right view means that on that picture you will have both coronaries on the inner curve, that is where the wing is pointed out here. And on the other side, you will only have the non-coronary cusp. And so that's typically a slight REO view.
Yeah, exactly. And so what we found is that you can use these landmarks to determine when you can be commissurally aligned. And we'll have talked to you about that in detail a little bit more. But we can go to the next slide now. So the way we found this to be very effective, it's really a simple two-step approach. But before that, you have to recognize that we want to insert the valve with the flush port down at 6 o'clock. So if we could focus the camera on the delivery system here.
Can I have the camera
right there,
here?
perfect. Yeah, so if we can straighten it out a little outside to 6 o'clock. And see exactly. So we'll always go in at the 6 o'clock angle, and we're just going to let it glide up and around the arch that way. So we can go ahead and I think start advancing here.
Yeah, and we can put fluoro on
and
the
you can show
picture.
fluoro now, and then our slide on the other, please. And so anyway, so we're going to go ahead and advance now at 6 o'clock, and you can show us the slide, please, again. And I think one thing we found is really nice with this device is it's just so flexible around the arch. It really can take on the most challenging arch anatomy.
Okay, just a moment.
Yes, louder back.
Perfect. So
coming up now with the valve, as you see, out through the sheath. good. So we can just pause here. You will see here also that when we're going up, you will see the wing here is on the left-hand side. It's on the inner curve of the aorta here. Then we'll cross the arch, and then we'll reassess.
Perfect. And so can we have that slide back up again here? Perfect. So our first step is what we call this a two-step approach: is confirm and then achieve. We first want to confirm that we are not misaligned, and then we want to achieve an optimal alignment. So what we do here first is go into left-right overlap, and we will look for a perfect alignment. Would be being in a 2-1 orientation, 2 posts on the outer, 1 on the inner, and then we want that wing to be on the inside.
Ready?
And we can see that we have an optimal orientation here, right, guys?
Yes. So we have one wing on the right side. That's the inner curve, which is the correct orientation.
Exactly. And if we could bring the valve maybe down to the tip of the nose cone when we get a chance. Perfect.
So then we'll go over to the left to the 3-cusp view again.
Yes, and so we put the marker at the top of the pigtail. We think this is the most effective way for reorienting things. But so what now in that step, we've confirmed that we will not be misaligned. We can actually use this valve to be 100% that we are not misaligned. I think that's really the only device that we can be quite this confident with.
Field.
So now we're going to go to our 3-cusp view. And what we want to achieve here, can we have the slide back up again now on the right, on the screen? What we want to achieve here now in the 3-cusp view is this kind of 1-1-1 of the post separation and these 2 wings, which we showed you earlier. Now, because we see 2 posts on the inner curve here, we're actually going to counterclock the device instead. If we would have seen 2 posts on the outer curve, we would have clocked the device. So Andreas will counterclock the device here, and it really requires quite a bit of turning at the device level in the back here, though there is very little turning. We've done this on bench testing, actually at the inner level. Less than a 30-degree turn will actually happen to achieve this, so it's very small changing there. If you could put the hands on the sheath.
So now I have turned 180 degrees at the handle, and we don't expect any movement at the annular level until I turn a little more. So at about 3/4 turn at the handle, that will have translated to the annular level, to the tip of the catheter. So I'm just going too slowly, so not to overshoot.
It's starting to turn. Come around, starting to turn.
So we're waiting for the wing to appear on the inner curve. We see the wing on the outer curve becoming a little bit smaller, so the wing on the inner curve will soon come.
And you can also see that those 3 posts at the top are starting to separate a little bit there too. You can really use both of those things depending on the case and in which you can see better. But we really do like seeing both of those wings on each side here. We're getting very close.
A bit more than 3/4 of a turn.
Looks like you're very close to having achieved that 2-wing appearance there. And again, this is, we've already achieved alignment. This is just trying to have even more perfect alignment in this case here.
Yeah, so from the beginning, we were less than 30 degrees off anyway.
Yes,
so now we have the 2 wings.
Yeah, almost.
So there you can see this 2-wing appearance, 3 post. Sometimes it can be a little challenging to notice at the higher parts of the post, so we look at the little lower part of the post there. But I think we look good here, guys. So I think this is a place where we can.
So then, according to our instructions, we should here slowly release the stored torque.
Absolutely.
And it should stay stable at the tip, which it seems to do here.
It's exactly.
You can see it here when it's actually it was 3 o'clock, now it's back in this.
Yeah. So now we need to go down to have the dot approximately at the annular level. So maybe we can give some contrast. Contrast, please. A bit more. Fill up the pigtail. Okay,
Perfect.
pigtail seems to be in place. So that means we need to advance the whole system. And from now on, we do not turn anything more. Now we just do the implant just as according to the instructions for use.
Exactly.
Which means putting the dot about here. Take a shot here. Contrast, please.
Yeah,
great.
Okay, turn the first knob slowly.
So now we'll open that upper crown here. I think another nice feature here is it's just such a stable deployment at this point.
Good.
Great, looks good again.
Okay,
so we'll keep going with the rest of the one. The patient's doing well and stable here.
And the idea is to have the slight forward push during this process, have it lean a bit on the outer curve.
Yep.
Which it seems to do here. So far.
Now hard stop, first one.
Yes, contrast again. Seems still good. So then we take back the pigtail, not to jail the pigtail behind the stent frame.
good.
So now it's just to deploy the step 2.
Now,
Ready?
and then we will.
Yes, I have a slight push on the system.
Looks good.
Open up quite well.
Yeah.
Yep.
Maybe take back the
Great.
wire a bit.
And what we can already see here, guys, is that we have a
And just,
very good
so-
alignment just based off of the orientation of those 3 posts
Okay.
and how they're kind of almost perfectly separated there. We know that we've achieved probably within 10 degrees of perfection in commissural alignment, which
Can
is
you go forward?
really nice and is hopefully you can appreciate was really quite simple to achieve. So now we'll remove this delivery system here. She has a pretty small ventricle, so the wire is a little more challenging manipulation from an ectopy standpoint. Yep, perfect.
Going back, up, leaving the wire in.
And
You will, with this valve, it's not a
Stop here.
failure to post-dilate. We expect post-dilatation maybe between 30 and 60%, depending on which center and which strategy you use. And we aim for perfection too, so if there is a leak, in this case, as you might have recalled from the introduction, there is quite some annular calcium, which is the predictor for leak, although this second generation Neo2 has a much better skirt than the first one. There's still some possibility for a leak if you don't post-dilate.
yeah. Yep.
So the question is now, the big question is leak.
There's a little bit of wire leak and probably a little bit of PVL there too, I think. So I think we go ahead and take the 20 balloon.
Yeah.
Yep. And we'll go ahead and
So
post-dilate.
if there's any doubt, we will post-dilate.
I think we're okay, Andreas. We can look after we post-dilate.
Yeah, this is a 20 balloon, right? Yeah. Great. And was measured at 19.9. Sinotubular junction is almost 25. So from that part, there's no risk, I think, of using this balloon.
Exactly. All right.
In place.
Okay, wait.
Hook up same system again with the wire pacing. So red here, black to the Safari wire.
Great. Looks good.
So
This looks very nice.
Pacemaker ready. Balloon is ready.
Balloon ready.
Okay, pacing on, please. Balloon up. Balloon down. Pacemaker off, please.
Great.
So you could see some expansion of the stent frame.
Take out the wire or
I think we will not
Different
post-dilate with a bigger balloon, so that means we usually take out the wire and the balloon at the same time.
Fuck.
Withdraw the wire a little.
Yep.
Gently go back on the balloon.
Great.
So the gradient seems, if anything, even lower than before.
Yep.
As expected, with a bigger size. And I don't know, can we see any paravalvular leak?
Not much.
Probably not much.
I think time to do that aortogram.
Yeah.
All right.
I think it's fair to say that this prosthesis is quite favorable in small anatomy since the gradients usually are really low. And it also has a low pacemaker rate, maybe not relevant to this case, but still.
Yeah, and I think it's also important to mention with our more aggressive pre and post dilation strategy, we've not seen an increase in pacer rate. Still having a pacer rate on average about 4% of patients have received a new pacemaker after these cases. So very encouraging. So,
okay, we'll just adjust the image to have a good image here. Then we'll take a fairly big shot, 20 cc's of contrast to make sure we see everything. And you will see the coronaries here as well too. So you see here a good coronary filling, of course.
Very nice.
Perfect.
See the mitral calcium. You see also on the image that there's virtually no leak at all, and a good placement both with rotation and with depth of the prosthesis.
Absolutely. So trace PVL, perfect commissural alignment. Very easy to do, I think, as this demonstrates. This technique with this device is, I think, really nice for looking at a patient who has a long lifespan ahead of them to leave their valve options open and their coronary access open for a long time.
Yeah, and you will notice there's quite some coronary calcium here, so it's not unlikely there will be a need for coronary access in the future.
Great.
Good. Are there any more talking points relevant to this case, do you think, Chris?
No, I think this displays all the benefits of the device nicely. So I think we can let the panel take the rest of the discussion.
Wow, that was a very nice demonstration, not only of commissural alignment, but also of a very controlled and safe, accurate implantation. Maybe, Raj, a question to you. In your experience, do you also feel that it becomes very reproducible, that the variability between operators becomes less because of all these features of the technology? You have the sealing wrap that will take care of the leakage, but I would believe that the radiopaque marker makes it so easy to position the valve. What is your opinion on that?
Yes, no, I think that's absolutely correct. I mean, as we do more and more of these procedures, the point I think you're alluding to is training and consistency. And if we are able to have a systematic approach that we all adhere to, then we get more consistent delivery, more consistent results because of that. And the radiopaque marker does add to that. It takes away the subjectivity. So I completely agree with that point. I think it starts earlier on as well. I think we need to be much more rigorous about the pre-planning, reading the CTs, understanding that, planning the valve implant, and then the procedure itself. So I think there are multiple steps to standardize.
Yeah. Mohamed, in terms of training this TAVI with this device, is it difficult to train novel operators with this? Is there a long learning curve?
No, actually, it's probably a very short period that you need in order to understand the properties of the device and how to implant it. But it's actually, compared to other devices, rather straightforward. Of course, if you add these nuances, then it gets a little bit like you need a little bit more time, but it's rather straightforward, and I personally believe it's more or less simple.
So what is the difficult part of learning to implement this commissural alignment technique? I have the impression that you have to learn to recognize what you need to see, like the wings and the posts. Would you agree?
Yes, I mean, the most important thing, and I think this is helpful in general, not only for obtaining commissural alignment, but for a deeper understanding of the anatomy and what we actually can see on fluoroscopy. So it's this whole concept of commissural alignment helps us a little bit to understand a little bit in more depth how to visualize the aortic valve fluoroscopically, angiographically, apart from the usual three-cast view. So, I mean, we have a whole S-curve, as you know, where we can see the leaflets in plane, but we can isolate different leaflets, we can overlap different leaflets, and then we can understand also where the commissures are. I think this gives a little bit more, a deeper understanding of the anatomy, which helps for commissural alignment, but definitely it gives us also the possibility to learn more complicated procedures such as basilica, or maybe in the future like other leaflet modifying techniques, which all depend on understanding these anatomical considerations and how to look at the leaflets from different views.
Andreas, coming back to the technique of commissural alignment in the cath lab, we saw you nicely illustrate how to maneuver and do the slow manipulations of the handle. Is this dangerous? Have you ever seen hemodynamic instability during those maneuvers, or is this well tolerated by the patients?
I say in the beginning, when we started with this, I wasn't so convinced. It felt a bit unsafe to be all the way down in the annulus almost to do this manipulation. But then as we have done it now in a standardized way, we have not actually seen a single patient yet with a stroke or with any hemodynamic instability. We have discussed this with other operators. Some centers have felt that sometimes you are in a rush, you just implant the valve, it doesn't matter on the orientation. But in our experience, we always have had the 2 to 3 minutes to rotate, and the patient's blood pressure has never gone down. It seems to be well tolerated to have this prosthesis unexpanded in the annulus for a couple of minutes.
Yeah, and you had this nice rule of thumb where you demonstrated that you keep the radiopaque marker on top of the pigtail, correct? As you're doing this maneuver, I think I like that. That's a nice takeaway to make it standard, to make it more standardized. But do believe it makes a difference that you should not have the entire valve, your entire bioprosthesis across the valve. So by using your technique, you stay a little bit out of the critical segments of the leaflets itself. So I don't see there a lot of harm then as you are doing your maneuvering. So I very much liked your technique. Back to Mohamed. You do like almost 1,000 TAVI cases a year. What is your percentage of patients with an early discharge? So an early discharge, I would say, within 48 hours. And would this platform lean itself for early discharge?
Yeah, it's a good question, actually. So in Germany, it's a bit difficult to discharge patients extremely early, so within 1 or 2 days, because of the reimbursement system. So we are a bit limited by that. But on the other hand, if we would like, or if we had the possibility to discharge patients early, then definitely a platform that gives you a single-digit pacemaker rate in the majority of patients would be a very advantageous platform in the context of a lean procedure, as you just mentioned. Mm-hmm. So pacemaker is one thing, of course, but there are other metrics. But definitely the most rate-limiting factor in discharging patients would be actually the need for assessment of conduction disturbances afterwards.
Yeah. So, Raj, you are also involved with the Polestar trial, right? Where we try to identify upfront the patients who would qualify for early discharge. And of course, then you would want to have a platform that has low PVL rates, low pacemaker rates, and is a safe procedure. Do you think, in your opinion, that Accurate is a good product for an early discharge strategy?
Yeah, I mean, the data would certainly support that. Single-digit pacemaker rates, low-profile device. So I think all the objective metrics suggest that it is a good device to facilitate early discharge because of that single-figure pacemaker rate that's coming out. I think that it's yes is the answer.
Yeah. So Andreas, what is the average hospital stay in your center?
I think about 50% are discharged after one night, an additional 40% after 2 nights, and then about 10% need to stay longer. And that has been actually that way for a couple of years already.
Yeah, and your relative proportion of accurate cases is quite high, right?
It's rather high. It's about 70% of patients.
Yeah, so that's very good. So let's go back to the issue of coronary access. Have you encountered already cases after an accurate procedure, like months or a year after, and the patient required coronary access, so a new angiogram? Have you had those cases already?
Yes, of course. Yes, we have.
And any tips and tricks in terms of guiding selection? Do you accommodate according to the prosthesis?
Well, I would say with the Accurate, it's very similar to a regular coronary access. If we look back to the data from Dr. Barbanti in the Reaccess study, not even one single patient with an Accurate in their study where there was a failure to cannulate the coronaries. So that even works if you have the prosthesis rotated at random. That means without any commissural alignments. So for some reason, the design just facilitates coronary access in most patients. So I think it's easier in general already with the Accurate than some other platforms.
Yeah, Mohamed, what is your take on that? Have you encountered already accurate cases that required reaccess of the coronaries?
Yes. So, of course, not a very big percentage of patients yet compared to other devices which are older. But as I agree with Andreas, it seems to be straightforward, and the data are supporting this. So I think the concept of commissural alignment is probably important for access, but it may be even more important for this particular device for repeat interventions. The explanation why access is easy, even if you have malaligned commission, is actually straightforward because you have a lot of or much less interaction between metal and artery above the upper crown, so you have almost no metal up there. So I'd like to call the prosthesis, it's supraannular, but it appears to be like short frame. Like this may probably explain why access is more or less straightforward.
I would agree. I think for an accurate, when I need to re-access the coronaries, I also would rely on my standard shape guiding catheters. And as compared to other self-expanding supraannular functioning valves, I would go like a size smaller. Because it's a different kind of maneuvering and navigating in the prosthesis with each different device. So with that, I think we are at the end of this webinar. It's already 1 hour in almost. And I can say that this was a very nice session. It was well documented, well illustrated, and also well discussed with a great faculty. So thank you very much, Professor Abdel-Wahab. Thank you very much, Professor Cabana, and thank you very much, Dr. Ruck. I hope also the chat session worked well. Joanna has taken care of the chat questions, so I trust that will be okay as well. So what did we discuss in the last 60 minutes? Well, first of all, we demonstrated the new features of the Accurate Neo2 with the radiopaque marker, but also the sealing cuff. So Dr. Ruck already demonstrated earlier at PCR this year that there are quite favorable outcome results with less than 2% more than mild PVL, a single-digit pacemaker number, so very competitive as you compare it to other technologies. And then the main piece of this webinar was, of course, about coronary reaccess. And this is becoming a very important aspect of contemporary TAVI as we are moving to younger patients with longer life expectancy. And we learned from the first presentation that up to 50% of the patients with aortic stenosis also will have coronary artery disease. So it is quite intuitive and quite reasonable to believe that some of those patients will require a new coronary angiogram at one point in time. And this is where coronary accessibility is very relevant. I think the technique of commissural alignment with the Accurate Neo2 is under development, but I think it's already quite there. It is already being done in a lot of the centers. Not only in Karolinska or in Leipzig, definitely also in Rotterdam, and I'm sure that also Oxford will follow soon. And it does make a difference. If you have this commissural alignment, the reaccess to the coronaries becomes more standard practice. With that, I would like to thank the faculty again. I would like to thank Boston Scientific for supporting this session. And I'd like to thank EuroPCR for having us. And thank you for attending this great session. Thank you very much. Stay well.